All right, welcome. Today we're going to be talking about schizophrenia as well as other schizophrenia-like disorders. Okay, so we have some pre-lecture questions. Number one, define avolition and allogia. Define avolition and allogia. Number two, what is the diagnostic criteria for schizophrenia? Number two, what is the diagnostic criteria for schizophrenia? And number three, how long before a patient who is prescribed an antipsychotic for schizophrenia should they expect to wait before they see any improvement in symptoms? So number three, how long before a patient who is prescribed an antipsychotic for schizophrenia, how long should they wait until they should expect to see improvement in symptoms? And we'll give you those answers at the end. Okay, so with regard to the symptoms of schizophrenia, there is no single sign or symptom that is characteristic of the disorder. Rather, it is a group of symptoms that involves a change in the manner in which a person thinks, feels, and relates to other people and the outside environment. Now, schizophrenia has three phases. It has a prodrome, an active phase, as well as a residual phase. Now, there are three different criterion of symptoms that are displayed by individuals with schizophrenia. Now, these include positive and negative symptoms, as well as disorganization, and this includes the manner in which a person thinks and behaves. Now, positive symptoms, which are also known as psychotic symptoms, consist of manifestations that are perceived to the patient that should not be there. Now, these include hallucinations and delusions. Now, to distinguish the two, I think of eyes and ears. Hallucinations are perceptual or visual disturbances, whereas delusions are beliefs or thoughts. Each of these are present in the individual, however, they should not be there. In contrast to positive symptoms, which consist of delusions or hallucinations that are present that should be absent, negative symptoms consist of emotional disturbances that are absent but should be present in a normal individual. Now, this can include anhedonia, which you refer to an inability to feel pleasure in something that would otherwise be enjoyable to most people. And overall, negative symptoms displayed by these people are more of a blunted effect. They just don't display emotions normally. Two additional key terms that are related to negative symptoms include avolition and allogia. Now, allogia is a defect when it comes to speech. So these individuals will not expand in normal conversation, so you will be unable to have a really regular conversation with these individuals. Additionally, if you ask them a question, they will respond in brief and will be unable or unwilling to expand on that. You'll get very brief yes or no responses, if that. Whereas avolition is a lack of initiative or goal-oriented behavior. So these individuals will not be the ones that go to PA school because they won't have that. They're not goal-driven. They don't have that motivation. They're not going to attend school. They're not going to pay their bills on time. That is a lack of avolition that is present in these individuals, which are both negative symptoms. So avolition and allogia, negative symptoms. The last category associated with schizophrenic disorder is disorganization. This includes disorganized thought and disorganized behavior. Now, this includes perseveration, which if you remember, that's an inability to kind of change topics, so you're moving on, so they don't see those social clues to stop talking, or they'll keep doing a gesture that should not be being initiated. And they also have disorganized speech. They say things that do not make sense. These are all considered thinking disturbances, which is associated with disorganization, which is seen in schizophrenia. Now, with regards to disorganized behavior, this includes catatonic behavior as well as an inappropriate affect. Now, inappropriate affect is a inability to adapt to emotional expression. So if someone's sad, you're unable to be sad with them. You might joke or smile when you should be sad, etc. Whereas catatonic behavior is a decrease in the reactivity that an individual has to the environment. This can include a stupor. You could have motor rigidity, and you can also have purposeless excitement. So excitement when you really shouldn't be excited. Now moving on to diagnosis. Now the criteria for diagnosing schizophrenia can appear a little complicated, but when you think about it, it's pretty simple. First, there needs to be an effect on your ADLs, so impaired functioning. Number two, it must require two symptoms, so number two is two symptoms. And number three, these symptoms must be persistent for at least 6 months. And of those 6 months, there must be at least 1 month of symptoms from criteria A. Now, criteria A consists of positive symptoms, negative symptoms, as well as disorganization. And those, as you remember, were the thoughts and behaviors that are disorganized that we discussed previously. So at least 1 month of those previous symptoms that were discussed, and a total of 6 months of overall symptoms that can be outside of that criteria. And I included here a chart down here in the bottom that describes the additional symptoms that can be consistent with schizophrenia. So now we're going to be getting into the additional disorders that fall underneath the schizophrenic spectrum, and these were listed previously on the classification slide. Now the first disorder to be discussed is delusional disorder. So delusional disorder is a group of symptoms that do not fully meet the schizophrenic criteria. Now, to be diagnosed with delusional disorder, you must have at least 1 month of delusions, so that makes sense. And this isn't very common. The next condition is brief psychotic disorder, and this is, as I described, a brief psychotic disorder. This is psychotic symptoms that exist from 1 month to 1 day, or 1 day to 1 month. The next disorder, which falls within this schizophrenia spectrum, is schizophreniform disorder. So it's a form of schizophrenia. It presents as an acute psychotic disorder that has a rapid onset but lacks a long prodromal phase. Now, the main difference between this and schizophrenia is that it lasts for less than 6 months. But for it to be considered a disorder, it must last for at least 1 month. And because I said it's the same as schizophrenia, you're going to also have associated positive symptoms. So you must have at least 2 positive symptoms. So the criteria is at least 2 positive symptoms, and it must last for at least a month, but less than 6 months. And you must also rule out other causes such as bipolar, schizoaffective disorder, as well as major depressive disorder. The next disorder is schizoaffective disorder. So when I think of affective, I think of affect, such as the emotions. So you have schizophrenia and emotions. So when I think of emotions and disorder, I'm thinking depression as well as bipolar. So schizoaffective disorder is the boundary between schizophrenia and mood disorders. Now it consists of uninterrupted periods of a major mood disorder, such as depression or bipolar, as well as criteria A of schizophrenia. Remember, criteria A is the positive and negative symptoms as well as disorganization. Now, the positive symptoms must last a minimum of 2 weeks and must be in the absence of major mood episodes. So they're going back and forth. They don't occur together. Now, the remainder of the time consists of mood disorder symptoms, and these predominate throughout the majority of the course of illness. Now we're going to get into epidemiology. So with regards to frequency or prevalence of the disease, it appears there is a difference based on gender. The most recent evidence suggests that men are about 40% more likely to develop schizophrenia as opposed to women. So I'm glad all you ladies are happy to hear that. And there are 2 proposed hypotheses to this rationale. The first is that it is a genetic disorder that the schizophrenic gene is expressed differently in men than women. And the second hypothesis is that there are 2 distinct subtypes of schizophrenia, which will have a difference in onset based on sex. Now, as a tool to remember the gender differences for individuals with schizophrenia, I use kind of 2 different characters to represent the men. I think of a young man who is by himself at the library, and to represent the women, I think of a older woman who is on drugs, who is at a music concert. So for the young man by himself at the library, they're a young man, so they're between 18 and 25. They're by themselves, so they lack social functioning. They're withdrawn, and they're passive. And they're at the library, so nothing fun at the library. So they have negative symptoms. They are anhedonia. They lack pleasure because they're at the library. Who has fun at the library? Whereas the woman who's on drugs, who's at the music concert, she has good social functioning. She's also older, so she's between 25 and 35 years old. She has good social functioning, but because she's on drugs, she has those positive symptoms such as hallucinations, paranoia. They also are more emotional and impulsive, also due to the drugs. So kind of silly, but I like it, so cool. Now there has also been a cross-cultural comparison that has shown that countries that have a greater tolerance or acceptance for individuals with psychotic symptoms will have better clinical outcomes in treating them versus the countries that are less accepting. Now, just like many of these other psychiatric illness, there is a genetic factor, and this has been proven in twin studies, as well as a study performed by Leonard Heston. So Leonard Heston initiated a longitudinal study which indicated genetic factors do play a role in development of schizophrenia. So Leonard, longitudinal, Leonard has schizophrenia, I don't know. And these other slides are basically saying the same thing, genetic factors. Now, schizophrenia typically presents between the ages of 15 and 35, so between adolescence and early adulthood. Now, it's believed that those who begin developing symptoms in adolescence have a worse outcome, and this is because they're not really able to develop normally, whereas those who develop symptoms in adulthood may have a better outcome because they did go through that maturing process before developing the disorder. So along with genetic predisposition, there may also be a linkage between schizophrenia as well as pregnancy or birth complications. So it's been found that individuals with schizophrenia were more likely than the general population to have been exposed to some type of problem during their mother's pregnancy. So this could have been due to dietary factors as well as a multitude of other complications that have yet to be fully understood. There may also be some form of association between viral infections, which seems crazy, and also neuropathology or differences in brain structure. Now, coinciding with that neuropathology, there has been studies that have used positive emission tomography or PET scans that have identified certain regions in the brain, specifically in the prefrontal cortex and the temporal lobes, that have been associated with schizophrenia. For example, individuals have been found to have a smaller hippocampus as well as a smaller amygdala. Now, there is also a hypothesis that believes that dopamine can play a role in the development of schizophrenia. Now, this grew because practitioners were prescribing antipsychotics to treat schizophrenia, and they found that there was improvement in these patients. So if you remember, most antipsychotics manipulate dopamine in some way. So because of this, researchers have believed that dopamine or a manipulation of dopamine in some way may be predisposing individuals to schizophrenia. There is also research into other neurotransmitters, and these are kind of the usual suspects. You have serotonin, which is used for everything. That's why SSRIs are so common. And there's also GABA, which has mainly a sedative effect, and glutamate, which you remember is the main excitatory neurotransmitter. So that makes sense because positive and negative symptoms are a little bit of both, right? So GABA and glutamate, you want to look into both of those, and serotonin, you're looking in because it's associated with every psychiatric illness that I can remember from this section. Now going on further into this long list of associations with schizophrenia, you have a linkage between social class. So basically, the poorer or the lower socioeconomic status, the more likely you are to develop schizophrenia. Similarly to the linkage in socioeconomic status, there's also a high association between migrant status. So basically, more likely to be schizophrenic if you have migrated to a new country. Now, an explanation for this phenomenon is that social adversity increases your risk for schizophrenia. So family environment also seems to impact the course of schizophrenia, but it does not impact the etiology or the cause of schizophrenia. So, for example, there was a study that found that male patients who relapsed seemed to negatively react to some feature of their relationship with their wives or mothers. So they had a higher expression of emotion. So there are a bunch of different disorders that, along with schizophrenia, can be related or impacted by a high um, expressed emotion. Now, patients with schizophrenia may also have a memory impairment, so they have deficiencies in their cognitive performance, as well as deficiency in eye tracking, so they'll have frequent interruptions, and this poor tracking may be a predisposing factor to schizophrenia. And in this image here is demonstrating the eye tracking pattern. So A is the goal tracking, B is a normal individual, and you can see that they track pretty well, whereas C, there is a huge amount of interruptions and there's not tracking poorly. They are tracking poorly with their eyes, so this individual does have schizophrenia. So a little weird, but kind of interesting. Now, the first line treatment for reducing these psychotic symptoms is antipsychotics. So these are, remember, the first and second generation antipsychotics, such as Geodon and haloperidol. So to remember, it does take about 2 to 3 weeks before an individual can see improvement in symptoms. And antipsychotics work best for treating positive symptoms. So the hallucinations and delusions, they do not work as well on negative symptoms. Now, there are side effects for these antipsychotics. If you remember, there are extrapyramidal and tardive dyskinesia. And I feel like people get these confused, and I don't know if everyone understands the difference. So, extrapyramidal symptoms, these are, they kind of look like Parkinson's symptoms. So these are the tremors, they're agitated, and they'll have just involuntary movements. They may have rigidity, they may have tremors, and these are the ones that can be treated with antihistamines such as Benadryl. So these can go away. Now, in contrast, tardive dyskinesia does not go away with treatment. So once these people develop it, they're stuck with it. So this, in contrast to EPS symptoms, this is mostly related to the face. So this is abnormal, like lip-lipping or tongue protrusion, chewing. It's just weird mouth movements as opposed to the characteristic tremors or muscle rigidity that is seen in EPS. So I think of tardive dyskinesia, I think of face and like lip, mouth movements, whereas EPS, I think of the general tremors and kind of extremity movement. Now, as I said previously, there are first and second generation antipsychotics. The second generation antipsychotics are referred to atypical antipsychotics, whereas first gen are considered typical antipsychotics. So just remember that naming nomenclature so you don't get confused. So second gen antipsychotics or atypical antipsychotics, so they're second gen, so they're better. So they produce less motor side effects. So they basically worked out the kinks of the first gen. So they're basically the same thing. They work just as well on positive symptoms. There's really not a huge difference as regards to negative symptoms, but they do significantly decrease these EPS and tardive dyskinesia side effects. So they're better for the side effects, but really have the same efficacy overall. Now this chart here shows the first and second gen antipsychotics. So really all the second gen antipsychotics will end in pine, P-I-N-E, except for risperidone. So remember that. This one down here, Solian or amisulpride, isn't sold in the US, so I'm not going to worry about it. And then there's only 2 first-gen listed here, so it is good to probably remember haloperidol as well as chlorpromazine, which is the, as we found out, the burping medication. So I'll probably memorize those 2, chlorpromazine and haloperidol as first gen, and then remember that the second gens end in pine, and then there is also risperidone, which falls into the second gen antipsychotic category. Also note here that the first gen antipsychotic that is listed here, haloperidol or Haldol, has the highest, basically the most associated with extrapyramidal side effects. But it's also the largest of the first gen with the dopamine receptor blockers, which is why you used to see haloperidol used quite frequently for as a sedative or a tranquilizer for acute psychotic episodes. So not great because of the EPS side effects, but it is good because it can kind of stop that psychotic episode. Now, non-pharmacological treatment include family-oriented aftercare. This is an attempt to improve coping skills of the family members. There's an emphasis on improving communication and problem solving. And there's also social skills training. And this involves modeling, role-playing, and social reinforcement. So you have social skills training as well as family-oriented care. Lastly, you have cognitive therapy. Now note, this is not CBT, this isn't cognitive behavioral therapy, this is cognitive enhancement therapy, so CET. Now this is designed for patients who have recovered from active symptoms, so they're no longer in that acute psychotic episode, but they do exhibit cognitive disability. So they may have like anhedonia or stuff like that. So this is cognitive enhancement therapy, which is designed to help with those cognitive symptoms. And there's also assertive community treatment. Now, this is a community treatment. So this is delivered by interdisciplinary individuals, so people from multiple different disciplines. They come together and basically help to treat these individuals. So it's a cohesive approach rather than individual specialties treating this individual separately. All right, and that basically concludes that lecture. I'm pretty excited. We're almost there. We almost have Professor Lasley teaching us surgery. Thank Jesus. So now the answers to our pre-lecture questions. We have define avolition and allogia. Now, allogia is a general lack of additional unprompted content seen in normal speech. So remember, these people are short in their responses and they don't expand in communication. Whereas avolition is the decrease in the motivation to initiate and perform self-directed or purposeful activities. So these people do not have initiative, they're not goal-oriented. Now, the diagnostic criteria for schizophrenia. What is the diagnostic criteria for schizophrenia? Remember, those were 1, it affects your ADLs. Number 2, it has minimum of 2 symptoms. So number 2, 2 symptoms. And number 3, must last for a total of 6 months. And at least 1 month must be from criteria A. And remember, criteria A are those positive and negative symptoms as well as disorganized thoughts and behaviors. And lastly, how long before a patient is prescribed antipsychotics for schizophrenia until they should expect to see some kind of improvement in symptoms? So how long after a person is prescribed an antipsychotic should they have to wait before they should expect improved in symptoms? And that is 2 to 3 weeks. And remember, those are positive symptoms, which is mainly what is being addressed with those antipsychotics. All right, well, that's it. And hope this was helpful. I'll see you guys in the next one.